Welcome back to the Surviving Cancer in Rural and Regional Australia information session. I hope you had a quick break. This final 1 hour session is devoted to answering your questions. We are keen to try to answer as many questions as possible, and thank you for your wonderful response. We've received many calls, faxes, text messages with your questions. I'd just like to say now we will not be able to get through all of them, but please check the back of your program to find out where to get more information. As you can see, all the speakers have joined me here on the stage, in addition to a couple of other experts. On my immediate left is Craig Underhill, Dr. Craig Underhill, who is a medical oncologist from New South Wales, actually the New South Wales-Victorian border, in the area of Albury-Wodonga. I'm pleased that Craig could join us at this information session today, as he has a particular interest in rural health issues. I might just start off with Craig before introducing our other expert. Craig, you've been in this area for quite some time and obviously devoted to treating people and supporting them. What do you see as being one of the key issues for patients and doctors and their carers?
We've seen a lot of terrific talks today and about a number of issues, but I think the really big issue for people in regional and rural Australia is how do we access these services? You know, how do we access the expertise, some of the expertise we've seen today within our local communities? You'll be aware of the COSA report, which is linked for the first time our knowledge of reduced survival rates in some cancers in regional and rural Australia with this access issue. So that was a report where we documented the level of cancer services right throughout the country and made that link between access issues and inferior survival. And for those of you who haven't seen that report, that's available on the COSA website, and it also, as well as making that link, looks at some of the possible solutions in how governments and health professionals may be able to start to bridge some of those gaps in regional and rural Australia.
Can I just ask you, from the doctor side of the equation, what keeps you going there? Or do you get a lot of peer support from other doctors, or who, when you have a bad day, is it just home you get your support from, or do you talk to colleagues?
Yeah, I talk to colleagues, and I have some terrific colleagues in Albury-Wodonga, two other medical oncologists, radiation oncologists, surgeons, GP friends, but also, have the support of my family and a social network in Albury-Wodonga. It's a great quality of life that we have there. I mean, often there's a lot of doom and gloom about all the negative things about living in the country, about healthcare, but on a day-to-day basis, we have a terrific quality of life.
Kate mentioned this whole issue of privacy, that you know the community, and suddenly you might be their doctor. Have you come across that issue yourself?
Yeah, it comes up quite a bit. I mean, it's always that, as Kate said, one of the good things about the country is that there is a sort of informal network throughout the community, and sometimes, we'll get a call saying, we know that Mrs. Bloggs is having chemotherapy at the moment. I noticed that she didn't pick up a paper this morning. Is she okay? And the palliative care nurses will go around and make sure that the patient's okay or whatever. So there's that informal network. But yeah, there can be intrusions of privacy, because some people, it's also, the flip side of that is, I can't go to the supermarket without being recognised by 10 patients and family members, and while it's lovely to have a chat to them, it's sometimes you forget and go in your worst tracksuit and haven't had a shave, and so there's a downside to it as well. So not everybody, sometimes there are obviously those issues of intrusion.
Yes, we might ask Graham about that later as well, because he must face that all the time. Look, last question before I introduce Dr. French. What's one of your frustrations in terms of dealing with us doctors in the big smoke? Do you Do you have any problems communicating, or is it a lot easier these days with email and internet? And
I think things have improved, but there's still ways I think that we can start to, in a more formal way, maybe template discharge planning and communications with letters. I think the move to have some care coordinators in metropolitan regional facilities is important, and links can be made between the care coordinators so that we can better support patients who are moving from regional centre to the metropolitan centre, say for some aspects of surgery and then back again. I mean, there's a lot more that we could do, and I think that's going to, in our own centre we have some research on this kind of area, and that's one of the focuses where on our next sort of year or two is in how we can improve those links for patient care and also mentoring of health professionals between the metropolitan and regional centres.
Okay, well, thanks very much. I might just introduce Dr. James French at our podium over there. James is going to select and read out your questions today. I happen to work with James. He's a breast and endocrine surgeon, a surgical oncologist here at Westmead, and James was also brought up in the country. As a radiation oncologist specialising in breast cancer, I'll be trying to manage any radiotherapy type questions. So we do have some specialists here, a surgeon, a radiation oncologist, a medical oncologist, and all our other experts will try and get through as many questions as possible. So I might just hand over to James immediately and to ask the first question.
Great. Thank you very much, John. I'd just like to reiterate what John said earlier. We've had over 250 questions to try and sort through, so there's obviously no way we'll get through it all, but we'll kick off with that. I think it's a very good question. This is, my wife looks so thin and sick. I'm scared to make love to her, but she thinks I'm rejecting her because of her cancer. What can I do to reassure her?
Okay, so that's a very important question. Probably I'll get Kate to start that one.
Jumping right in. Look, I think this is actually a far more common experience than people probably acknowledge or talk about. And I think the concerns that's being expressed in raising the question are very genuine and shouldn't be dismissed. I think there's a couple of things that you need to think about. I mean, one is it about that you actually will hurt her, and it's probably unlikely that you will, but also are there other reasons why you may be hesitating? It's certainly, we know that people that are on treatment or are feeling quite unwell probably don't have a lot of energy, and so there may be that if you were looking to become intimate with your partner, it may have to be different than the way you normally have done it before. There are ways around that. One of the most important things is around communication. Often what we do when we're intimate with someone is that we're maintaining a very close physical bond, and it doesn't actually have to be about the sexual intercourse act. It actually is how we go about maintaining that physical bond. If it is an issue in the sense that sexual intercourse may actually be difficult or not desirable, or both parties or one party doesn't have the energy to do that, it's thinking about what are the other things that you can do as far as cuddling, being together, stroking, and just holding each other that actually is really important. And sometimes if you start off with those little things, with some really good communication, other things just tend to unfold.
Okay, thanks. I might just ask Louise, do you have any other thoughts or comments on that question as a carer?
In terms of the person with cancer, it very often falls back onto them to signal that things are okay, I think, and perhaps the need is to follow their lead, and the need is to, I guess, it's about communication, isn't it? That if the person with cancer is okay with it, then the carer, the partner, will follow behind that.
Okay.
Yeah.
Kim, do you have any comments as well?
I work in gynecological cancer, so this is something we address with all of the women in our care because there are direct impacts on their sexual function. And I'd really like to reiterate what Kate said. It's about talking about it. This partner has said he's frightened to make love to his wife because he might hurt her. She might be thinking he doesn't like the way that I look anymore because of the cancer treatment. Often if you talk about that, go back to the things that worked earlier on in your relationship, setting the scene, getting rid of kids for the weekend, doing the things that will enhance anybody's sexual relationship with or without cancer, and take it from there.
Okay, James, another question.
The next question is, what have you sacked because of your diagnosis of cancer and there is no union to support you? What other rights or avenues of appeal do you have?
So, James, can you just repeat that?
Sorry, this person's asking, what if you've been sacked because of your diagnosis of cancer? And there's no union to support you, what other rights or avenues of appeal do you have to try and help out?
Kim, do you want to take that one?
Difficult if you don't have any workplace support. In that case, you would need to go to your the relevant department, so your Department of Industrial Relations, or indeed to a legal centre. You're going to need someone who can advocate on your behalf, particularly if your capacity to take on a big fight is diminished by your cancer treatment. So find someone within your community or a legal centre or your family solicitor to help you address that problem. And you might find that there are workmates in your organisation who can give you other leads to follow.
Okay, next question.
Next question is actually directed to Graham. Did you get depressed and how did you cope with that if you did?
There are times, I was talking privately earlier, that I've never been an overly optimistic person. I'm just the average, some good, some bad in life. But once I was diagnosed with a cancer, somewhere along the way I realised the mindset was going to play a big role, how I attacked the issue. And in the main, incredibly positive about it all, believing that once I'd chosen the course of treatment, after I'd researched it all, this was going to work for me. But there'd be times that, 3 or 4 in the morning, you'd wake up in a cold sweat and think the worst, what about the kids, what about my wife? So those sorts of things weigh heavily. But I saw that just as a challenge to test my true beliefs. And I thought, if I can beat this negativity, I can beat the cancer. And it got easier. It got easier as I developed a positive and maintained positive outlook and attitude.
Did anybody help you specifically? So you're not naturally positive and then you suddenly...
Well, I don't have any doubt that I rely a lot on homeopathic remedies and treatments, and my homeopath gave me some remedies that, hey, I don't know, but I was positive afterwards, and to this day I have a very positive outlook on it. And as I say, it sort of is like the snowball effect. When it starts to work for you, it becomes easier. It's like a muscle. The more you work it, the more you exercise it. And now I have an incredibly positive outlook on all aspects of life.
Okay. Craig, do you have any thoughts on this? Because obviously...
I think we often undervalue the resources that we have and the strength that we have. And I think Graham said some very important things there. And it's not until we're in a situation that we mobilise those resources that we even realise that they're there. It does require a little bit of reinforcement. I do think it actually also means going through some times of adversity. But I think I never cease to be inspired by a lot of the people I meet with cancer who turn that adversity to very good effect. If the thinking is, oh, this has happened, my life is destroyed and nothing good can come of this, well then I think that we're creating a way of looking at it that tends to emphasise that sort of experience. Whereas I think it's quite natural for those thoughts and feelings to come up. We shouldn't necessarily look at anxieties and stresses or feeling down as if something is wrong. It might be quite natural for them to come up, but through ourselves and through other people around us who can help, is to find what good can come of that adversity and to build on that. And when people find that there's much more that they've got within, and there's also very often much more that they've got in the people around them than they ever thought was really there. I was just chatting during the break, and a quote from Churchill, who I find a very interesting man, but he said, an optimist sees an opportunity in every calamity, and a pessimist sees a calamity in every opportunity. And I think I never cease to be amazed at how people turn calamity into opportunity and grow through the illness, which didn't seem possible at the start.